a start of a measles outbreak in Norfolk County, how do they report that to you? Are they required to say, okay, I've had 7 cases in the last week in my office, and they report that to you? Is that how it gets accumulated?
Through you, Mr. Chair, yes, they would be required to report measles. It's a reportable disease. But we gather information from a lot of different sources. Often we will get laboratory data coming back to us. If it's a reportable disease, someone is diagnosed with a reportable disease through a laboratory test, nasal swabs, nasopharyngeal swabs, blood work, anything like that. If that's ordered by the attending physician, then we get copied with it. As soon as we see that as a copy, if I saw something related to measles or mumps or German measles, then our staff follow up with the patient directly with that.
Okay, and then once, if it spreads to Haldeman, say like in Brant, which you look after currently, then that information, you relate that to the province, I take.
Yes, we report it. We get an outbreak. If there's more than one case, then it's an outbreak. And if we have an outbreak, then we have to put it into the system, which is reported provincially. And we get an outbreak number for that. And all cases that are connected with it, if there's any spread within the community, all those cases that we can prove that there's an epilink to a particular person, then they all get the same outbreak number, and that all gets reported back to the province.
Okay, interesting. Thank you.
Thank you very much, Mr. Columbus.
Thank you, Mr. Chairman. Dr. Locke, just going back to the cannabis grow-ups, and it almost seems like Norfolk County is the capital of cannabis anymore, with all the operations that are springing up. What are we doing to assist those people that have had to move out of their homes? Is the health unit, how do they handle that when someone has to move out because they cannot stand the odor, whatever else goes with it?
Sorry, through the chair. We would not be directly involved with that unless there was something that we could prove was a threat to human health. And right at this point in time, I don't know the composition of what it is that is offending people in these odors. It may be, it could be organic solvents which are used to extract some of the active compounds, or it could be just the plants themselves. I don't know quite what it is at the moment, so I'd like to find out from PHO, who would look at all different aspects of that and let me know if there was a health hazard. If there was a health hazard associated with it, we then would have to get air sampling to see what concentration those any of those compounds were in before we could say people have to move. Much the same as the hydrogen sulfide issue that we had. But we would not be telling people to move away from their home, and if they did, they probably at this point, unless we had further information showing that it was a problem, they would be doing that voluntarily. We would have no avenue to assist them. Thank you.
Thank you.
Mr. Sonnenberg?
Well, there are those out there who would suggest that the health hazard is marijuana is a mind-altering drug. I know a lady, she says, I grew up on a farm, I've been exposed to every conceivable odor that there is. But what bothers me is my grandkids are living across from an operation where the odor is mind-altering. Is that not a health hazard? People smoke it to get high, to bend their minds in some way. Is that not a hazard to young children exposed to this
Through
odor?
the chair. That may be true. I don't have any information or data to support that line of thinking at the moment. So I have to rely on the experts in the field to come up with that data to tell me what it is. if we've got a proven health hazard, we would have to address it one way or another. But until I have evidence to prove it's a proven health hazard and is having the effects that you're mentioning, I don't really have any legal way of doing anything about that. So those are the types of questions that I'm going to be, after we see this report from PHO, I will be, if it's not addressed in there, I will be going back to Dr. Copes and trying to get more detailed information on.
Mr. Columbus?
Just going back to this, do you or other medical officers of health from other jurisdictions, do you communicate this up to Health Canada about the issues that we are facing and other municipalities are facing with respect to the issues of odor and noise and that type of thing, with respect to cannabis production? Or would it be worthwhile investment of your time to organize something to get Health Canada to express the concern of the municipality?
I think that's a possibility, and I think, yes, that could be something that could be considered. But it would be better, I think, because there are other municipalities involved, as Dr. Cope says, and this is not an isolated thing to Haldeman or Norfolk. This seems to be becoming more of an issue. When it becomes more of an issue, it would be best for us to have a united approach to this rather than try to be doing things individually. So this is really in a way, a new problem to me in terms of the numbers of these things and the fact now that we're looking at legalization and whatever that means to the community, both legally and illicit forms of production. I think we need to really have the evidence first, and then we can approach it whichever way we think is reasonable to do that. But I think it's better that we do it as a group. Rather than our voice is more powerful as a group than individual approaches to this.
Certainly hope that we can be involved and take a leadership role, being that it is a problem.
Any other questions for Dr. Locke? Thank you for your update, sir. Moved by Mr. Brunton, seconded by Mr. Geisens, that the update from Dr. Locke, Acting Medical Officer of Health, be received as information. Any discussion? Those in favor of the resolution, that is carried. Thank you very much. We will now go to staff reports. In the agenda, we have three or four in front of us this evening. Actually, we have three to go. The first one is found on page 5. It's HSS 17-32. It involves the public health within an integrated health system report of the Minister's Expert Panel on Public Health. Marlene is with us. I know Susan is not. I have a feeling you're going to introduce, I think this is Lena.
Thank you, Mr. Mayor. I'm actually going to present the report this evening, and I'll introduce Kimberly and Lena in a subsequent report, if I may.
All right.
So the report, Public Health Within an Integrated Health System, report to the Minister's Expert Panel on Public Health, was released in July of this year, and it was at that time circulated to the Board of Health and also is within your agenda package this afternoon. Recommendations within the report provide a framework of the patient first mandate from 2015-16, but has limited information on the implementation of such a framework. The province is currently in a consultation period and is seeking input from its stakeholders until October the 31st of 2017. Staff is seeking direction to submit a consultation response to the Ministry of Health and Long-Term Care on behalf of the Board of Health. The report before you provides some of the far-reaching implications to be considered to Haldeman Norfolk for discussion today, including, but not limited to, governance structure and appointees and the local rural voice, the leadership structure, the boundaries within the report, the funding model, financial, staffing, and legal implications, local operational impacts, and change management and the impact of such a change. Staff encourage the Board of Health to take some time today to discuss and ask questions on the implications and present or recommend a position that they wish the Board to submit to the Ministry of Health and Long-Term Care. Staff have set aside time on Thursday to finalize the response after discussion at the Advisory Committee last week and the discussion this afternoon. Advisory Committee members have been invited, and any Board of Health members also welcome to attend the meeting this Thursday to finalize the response. A final response will be circulated to the Advisory Committee and the Board of Health prior to its submission early next week. It should be noted that on October the 12th, AMO released their response in opposition of the recommendations within the report. On a high level, simply stating that the benefits were not clear and significant and would create significant disruption to the system. They're not clear on what problem they are trying to address and not clear on the vision of the healthcare system. Furthermore, COMO and Alpha have also released their response last week, which is now within your package agenda, not available during Advisory Committee. Several other Board of Healths have also started to circulate their responses, so each of us can see what the response is. Overall, stakeholders are supportive of a strong public health sector in Ontario. However, there are many concerns with the recommendations in the report, which stakeholders are seeking consideration of the implications to inform the final decision of the Minister. Some of the themes throughout some of the documentations has been lack of implementation detail and the system disruption for the unknown true benefit, the need to protect the public health mandate to promote and protect the upstream approach of public health, the protection of the local voice and the influence on local health, the consequences to municipalities for those public Board of Health that are actually embedded in the municipal structure, financial and funding implications, the integration with other local services such as housing, employment, planning, and schools once removed from the municipal or local perspective, and the limited consultation into the report, including those embedded primarily within the municipal structures. Those are some of the themes that have been highlighted throughout the several reports that have been forthcoming. And with that, staff would be happy to answer any questions.
Thank you, Marlene. Mr. Black?
Well, it was a long report, and did read all of it and the AMO response, and you know, I trust AMO a lot because they are our municipal representatives, and they've done had a pretty thorough look at this. From the details, I mean, it's very difficult for me to say what's good, what's not good. But from a higher level, it's easy for me to say if their mandate is to increase efficiencies, reduce costs, provide a better level of service delivery, accessibility, give us more money from the province, decrease their downloads through you know, the rules and regulations, then I would say I could support, you know, those higher level items that if they're going to try to achieve that. So at the moment, you know, after reading it, it's unclear to me too. They haven't got it all figured out, so there still needs to be a lot more work done on it. And I guess all we can do is just wait and see until we see if they are fulfilling some of those things that are of a concern at this level. Okay, thanks.
Further questions? Mr. Bratton, then Mr. Oliver.
Thank you, Mayor Luke. Through you to Marlene. Marlene, I read through this again, and I've read it a couple of times, but I look at page 27 and 28 of the report from the expert panel, and I kind of wonder how there's a couple of questions. One, I wonder how well the province is going to listen. It seems to me that they've kind of have their minds made up based on the fact they've already established boundaries and the criteria. But then again, I guess they wouldn't ask for input if they weren't going to listen. At least you wouldn't think they would. But it seems to me that they've gone a long ways to identifying the structure they intend to implement. I guess my question to you is, do you have any response from Windsor, Essex? Do you know of any? And the reason I'm asking that, the mayor of that area, I believe, is on the panel, and I wondered what their response was to the overall expert panel's recommendations. Do you have any idea of that?
Through the chair to Councillor Brunton, a couple things. First of all, I just want to clarify that no decisions have been made. These are recommendations, and we are in a consultative phase, so it's yet to be determined what the final framework, et cetera, will look like. As far as Windsor Essex, that is not Board of Health that we've seen their response. We have responses from Peel, from Peterborough, and from Chatham Kent, I believe, are the three that we currently have. I'm sure more will be forthcoming, but at this point in time, those are the three. And I would say that all of them are at some level of oppositions based on the concerns of the implementation and the lack of the detail related to that implementation.
Okay, thank you.
Thank you. Mr. Oliver?
Thank you, Mr. Chairman. I have a couple of comments or concerns initially, Marlene, that I would pass on and would hope that it would become part of our response. First of all, with respect to the governance at the board level, I totally agree with what is in the staff report, and I'm looking at page 3 of our staff report, which is page 7 of our agenda in the second bullet. And this is admittedly from the expert panel, not our staff necessarily, although I'm sure we agree. But the fact is that our health unit and even our LHIN, or our portion of the LHIN that we're primarily in, is mostly a rural area, relatively large geographic, relatively small population. And I compare that with places like Peel Region or even Peterborough, where you have one large urban municipality that would tend to dominate things. And I think it's extremely important that if in fact this is the way we do go, that these new regional boards are created and representing the same geographic area as the LHIN, that there must be, as the expert panel are saying, a formula for equivalent representation. Otherwise, areas like Norfolk and Haldimand will simply be lost in the shuffle with the larger urban centers with much larger populations. And yet it's our smaller rural areas that are in most need of the kind of services that the health unit provides, in my opinion, where people don't have easy access to a family physician right in the city or right in town or any other health services. So to me, that's number one, that formula for adequate representation of rural portions of the of the new regional boundary must be recognized. The second one is in relation to funding. And I'm going to preface this, Marlene, with a question, if I can, and I hope I'm not showing my ignorance here, but of how many of the programs that are involved in this and would ultimately become part of a regional board jurisdiction are ones that we are presently cost sharing with the province here within Haldimand Norfolk Health Unit?
Through the chair to Councillor Oliver, I can't say specifically number-wise, but anything that's within the mandatory program envelope, which is the bulk or the most funding, is allocated. I think it's in the equivalency of $4 or $5 million. That is cost shared, and that's the that would all be applicable to the funding, as would the 100% components that are on the non-related programs. So your Smoke-Free Ontario, healthy children, healthy babies, those programs would also be included. Anything under the Ministry of Health and Long-Term Care and its mandate would be covered under that funding.
Okay, and I kind of assumed that might be the case, and you've heard this board and you've heard us when we have our council hats on over the last several years complaining about the fact that even though cost share programs or 100% programs are according to a formula, that over the years that there's been a lot of slippage and we're paying more than our 25% or we're paying something more than 0% of the 100% funded programs. So my personal view on that is if this changeover would eliminate that problem and would eliminate the necessity for the municipality to be cost-sharing more than it should on cost-share or 100% funded programs, I'm in support of that. I mean, that's a cop-out, Mr. Mayor, or Mr. Chair, and I apologize for that, but I think that's reality, and that would be part of it, perhaps. So maybe Marlene wants to respond to that.
So through the chair, again, no decisions have been made, and funding being one of them. If this is provincial and goes provincially, it could go one of two ways. It could be a provincial funded, which is questionable, or it could actually stay within the municipal requirement to fund it, and it would actually eliminate some of our say or our voice on how those funds are actually allocated, and we may actually just be advised of what our funding envelope is. So it's unknown, so it's not to be assumed that it would be uploaded to the province at this point in time.
Well then, Mr. Chairman, that really emphasizes for me that our second point of our response should be any support that this Board of Health would have for this proposed model is completely contingent on clarification of the funding responsibilities, if any, that would remain with the municipality.
Mr. County Manager, you want to add something here?
If I could, later today, this meeting will end and you will sit as county council, and when you're wearing your county councilor hats, there are going to be a number of concerns around this item that you have as a municipality as opposed to you have as a Board of Health. And one of the items on the information items that we'll end up to be discussing, I will bring forward under other business, is what we should do at Roma as far as our submissions and any requests for delegation. So I'm trying to say that later on today we're going to have a discussion about what our concerns are as Norfolk County as opposed to the HNHU board. And so money, I don't want to constrain your debate and dialogue here. It's impossible to parse. It's sort of all one and the same. But I think if it pleases this board, a report and a delegation with a number of the people at the table here in January would be appropriate vis-a-vis our financial concerns, because we have some and they're extremely valid, as opposed to your concerns when you're just thinking as Board of Health. I should point out that the recent gas emergency we experienced through August and into September this year was a really good example, a wake-up call for, I think, a heck of a lot of people in this room as to the importance of having public health as part of a functioning part of the municipality, because the coordination and the cooperation we experienced as staff, I don't know if that would have been possible if we weren't all part of the same organization. It ultimately would have cooperated obviously to an extent, but there was no barrier as between us, and that I would submit to you is a concern you might have as municipal councillors. It might be a concern you share as Board of Health members as well, whereas the money items are really going to be your concern as councillors as opposed to board members. If I may, and if that helps you frame your discussion to know there's another opportunity later on today and ultimately into January, I hope.
Thank you, Mr. Chairman. I appreciate that comment from the county manager. But I guess I still find myself saying it couldn't possibly hurt our position for the Board of Health to also express an opinion and concerns with respect to the funding, in addition to those we'll express as council when we get a chance. So if it's possible, I would still like that for the record to be identified, assuming there's support for that around the table. Thanks.
Thank you. Mr. Height?
Thank you, Chairman Luke. Through you to staff, it's on page 19 or 30 of our agenda. It shows boundary adjustments on the lines being done, so it looks like southwest Norfolk, basically my ward gets moved into the southwest proposed boundary. So is that correct? They're looking to move us out of Norfolk and Haldeman's area?
Yes, so through the chair to Councillor Height, that is correct. There is a small sliver of Norfolk that actually lies within the southwest LHIN. Those LHIN boundaries historically were based on population and access to hospitals, etc. There was a lot of work done on what the LHIN boundary should be. They did not follow municipal boundaries, which is part of the challenge moving forward. That part of Norfolk would then be encompassed in the southwest LHIN, where the remainder of Norfolk and all the Haldeman would be within the HNHB or the Hamilton, Niagara, Haldeman, Brant, LHIN.
Okay, so I guess how would it work? London would be the head office, sort of, for this?
So through the chair to Councillor Height, that's yet to be confirmed. Boundaries are yet to be confirmed. These are current LHIN boundaries, which are being considered. Through having come from the CCAC world and through that, we did utilize both of the LHINs, and the sliver of Norfolk did go to London. It has been suggested, and as through the consultation period and any conversations, we have not engaged with both LHINs as we've moved through the patient first exercises and committees. We've strictly been embedded within the HNHB as we've worked through other components of the patients first. So I think the commitment is that municipalities, even though boundaries would not necessarily align completely. There are several instances across the province. They have committed to only having to work with one LHIN.
Thank you for that. My next question is, under the recommendation, it says that basically the staff will submit a consultation response to the Ministry of Health by October 31st. So that's pretty short time. Will we actually get to see that response?
So through the chair, absolutely. So inviting any board member who would like to participate, we will draft it up and finalize it on Thursday, circulate it for any final feedback to all board members and advisory committee, and we will submit it within the timeline. We did appreciate that this was a tight timeline, and in consultation with the Ministry of Health, Mayor Luke, Mr. Cribbs, and myself did attend a session. There is a little bit of leniency, so if we find ourselves in a position that we'd like a little bit more time to just digest the final recommendation response, we can request that and advise the Ministry of Health and Long-Term Care.
Okay, thank you for that. So it was because of the short term that we don't have a response in front of us today?
Through the chair, if I can be perfectly honest, it's related to all of the activity with the hydrogen sulfide and many other priorities that a draft hasn't come forward sooner than this, and staff apologizes for that.
Okay, thank you for that.
Thank you. Any other discussion? Mr. Columbus.
Thank you, Mr. Chairman. Marlene, what is the target date for implementation that they have? And the more than 80 employees that could be affected, would they become Ontario government civil servant employees?
So through the chair to Councillor Columbus, implementation dates are unknown, final decisions are unknown, so it is totally unknown at this point in time and what would happen to those respective staff. It is something that we as staff felt important to outline in the report, that there are implications to our staff and different operational, legal and financial aspects of our corporation.
Mr. Oliver.
Mr. Chairman, thank you for letting me speak again or ask another question. My other question, Marlene, relates to the staff leadership model, I guess, that's being talked about. How many, with the proposed area that we would be part of, which I realize corresponds with the present LHIN geographic footprint, how many health units does that consist of?
Through the chair to Councillor Oliver, 5.
5.
So it's Brant, Haldeman, Norfolk, Niagara, Hamilton, and there is a little sliver of Burlington that's in this specifically.
Okay, so 4 existing health units with 4 existing administrative hierarchies of MOH and GMs and various other levels. With this proposed model at the regional level, do we have any, I'm looking at page 21 now in our agenda, which is the proposed leadership structure from the expert panel, I guess. It talks about a regional MOH as well as a local MOH. How many additional sort of senior administrative people would be created, or positions rather, with this structure? If it's just one, in other words, a new regional MOH and a board that is combined from all of the geographic areas, that's one thing. But do you have a sense it would be another whole layer of administration, in a sense, with the associated huge costs associated with that? Or do we know enough about it yet?
Yeah, so through the chair, unfortunately, we don't have those specifics. That, again, wasn't outlined in the report, and in any consultation with the Ministry of Health, that hasn't been articulated, nor was it the mandate specifically of the expert panel. It is understood that there would be a medical officer of health at the regional level, and associate medical officer of health or medical officer of health, whatever they title them, at each of the local sub-regions or each of the local areas. As far as the leadership structure, the primary leadership, or I would suggest the executive level leadership, would be restructured in some format, unknown again, and be localized at a centralized hub, and then there would continue to be some level of middle to lower level leadership at the local level is the understanding, but again, unspecified in the report.
And if I could, Mr. Chair, is it appropriate for this board then to express an opinion or a concern about possible additional administrative costs that would be created with this new model, vis-a-vis what we have now, where we have 5 independent health units with their 5 staff? I don't see any of that disappearing, Mr. Chair. If anything, I see another higher level of administration being created, and I'm not sure of the cost efficiency of that. So is that an appropriate comment for us to make, to express that kind of concern over creating more bureaucracy and therefore associated costs with this new model?
Through the chair, we can definitely include some commentary around that. It may be suggested, though, that there would be restructuring. So senior positions that currently are within our organization may be restructured into a regional structure. Again, though, those are presumptuous and assumptions, but we can definitely put some wording around that of the potential concern of what that might look like in a regionalized model.
Mr. Brunton?
Just a comment, if you look on page 28 of our agenda, criteria, and it kind of spells out some things the way they see it. And one of the things that caught my eye, it says about the 4th point of the criteria, it says, whenever feasible, move existing health units in their entirety into the same regional health entity catchment area. And to me, that's a major undertaking. If you look at the Lynn boundary, Councillor Oliver or Marlene just described with Niagara, Brant, Haldeman. If you put all those and move it, who knows where to go, but that would have a lot of implications. So, with staffing and costs. So I think there's a lot yet that has to be determined or at least brought forward to let us know how they would implement that. Because we're kind of down here, I'll use the term on the lake, and that takes in one massive area. So as Marlene says, there's a lot of unknown answers right now. So anyway, just a comment. Thank you.
Mr. Columbus?
Mr. Chairman, thanks. Marlene, can we kind of ask them that we're anxiously awaiting to see a business plan with respect to this proposal?
Through the chair, the implementation plan has been requested by, I would say, all stakeholders. It does not exist, but we can definitely put in the recommendation that one would be sought after before any such implementation was actually implemented.
Because that would kind of answer Councillor Oliver's question as to whether the cost will be more or less if we saw the business plan. At least we get a better handle on it. Maybe we should send something up to pipe to them.
We can definitely include that.
Any other questions or comments? I'll move to the resolution on this report. I'll read it first. That staff report HSS 1732. This is public health within an integrated health system. Report of the Minister's Expert Panel on Public Health be received as information and that the Board of Health for the Haldeman Norfolk Health Unit direct staff to submit a consultation response to the Ministry of Health and Long-Term Care by October the 31st, 2017. Roger Geisens has moved. I will need a seconder. John Wells has seconded. Resolutions on the floor. Any discussion? Those in favor? Carried. Excuse me. Next staff report you will find on page 62 of our agenda. Mr. Sluchenkov, I'll turn things over to you. This is 1758, audit response to the meeting date and procedural bylaw requirements for this Board of Health, and I know Andy, you're on as well, so. Okay, sorry, Andrew, I'll let you take it away. Page 62.
Sure. Thank you. This report is essentially to bring Council's procedural bylaw to the Board of Health. It was a practice done in the past to have a very similar bylaw, but it hasn't been updated. The biggest change is the requirement from the audit to have a set meeting date. So currently we now can meet whenever we want, but what the ministry wanted was for us to set a fixed meeting date. So what we're proposing is the first Tuesday of the month at 2 o'clock every month will be the Board of Health meeting. The chair may want to consider canceling the first one because we just had one tonight, but we'll see in 2 weeks if that's the way we need to go. But there will obviously be an ability to schedule special meetings or emergency meetings, so it really doesn't limit anything, and it kind of combines our current way of doing business in council with the Board of Health, which has been the previous practice. The thing I would mention is that at this point we would look at further details of considering governance structure of the board and the Health and Social Services Advisory Committee, but with your last report we think it's just kind of a good idea to keep on going with the general nature of how we have done business previously and see what those results are before we examine any structural changes. And with that, I'll answer any questions.
Thank you, and I'll just have a quick question. Marlene, if we were to pass this for the first Tuesday, that's acceptable, and secondly, it doesn't make sense. Our next council meeting or council business date is November 7th, which is 2 weeks hence because of the fifth Tuesday next week. So we could begin it on the first Tuesday of December. Is that okay?
Thank you, Mr. Mayor. We just need to ensure that the schedule enables us to have a meeting with the advisory committee for their input and feedback, and then readjust the schedule to keep within that. We won't have anything for November the 7th. We won't have an advisory committee until I think it's the third Thursday of November. So December, the first week in December should be adequate.
So, Mr. Clerk, we will be getting a revised procedural bylaw when everything is figured out, if I can use that term.
Through you, Mr. Mayor, yes,
Okay.
the procedural bylaw is attached, and we
Yes,
look for the Board of Health to approve that tonight so that for our next meeting it would go into effect, and it really mirrors the council's current procedural bylaw. It used to be in 2013 it was mirrored to council's, but there have been a number of changes with council's procedural bylaw that haven't been impacted into the Board of Health since that time.
Council, the procedural bylaw presented, I did note, suggested a 2 o'clock start on the first Tuesday, correct? Okay, I leave it open for questions to staff. You're happy with 2 o'clock on the first Tuesday of the month? That's up to you. Any discussion? No questions? Well, let's get to the motion and we'll go from there. Moved by Mr. Columbus, seconded by Mr. Sonnenberg, the staff report, EBS 1758 regarding audit response, meeting date, procedural bylaw be received, and that the revised procedural bylaw for the Board of Health be presented to the board for adoption, and it's certainly printed in our minutes here, our agenda. Okay, discussion on the motion. Those in favor? That was easy. That's carried. That's making me nervous, Mr. Clerk. How easy that was. Good recommendation, right? Okay. I think we've got another report. We do on page 89, HSS 1731, Provincial Alcohol Strategy. Marlene, I'll turn that over to you, please.
So, thank you, Mr. Mayor. This report is seeking support to endorse a provincial-wide alcohol strategy on safe consumption of alcohol. I just want to be clear that this report is not saying to stop drinking, but to create an awareness of the risks and to start to advise the community of the responsible drinking guidelines that are shared within your packages on page 26. I'd like to take this opportunity to introduce and to welcome to Haldeman Norfolk Health Unit. Sitting beside me is our new manager of health promotion, so we'd like to welcome her. She is covering for Susan as Susan is on other county business today. So welcome, Kim. I'd also like to introduce Lena Hansen, and she's been with the health unit for several years, and she is the author and the expert in the alcohol strategy, and she's going to walk us through the report on some statistics within the report, the responsible drinking guidelines, and some policy interventions that have been proven to be effective as we move forward. And with that, I'll turn it over to Lena. Thank you.
Well, Lena, welcome, and I got you and Kim confused, and I apologize for that. So now that I know who's who, I'll just turn everything right over to you. Thank you.
Thank you. So as Marlene mentioned, my name is Lena Hassan. I'm a health promoter in the community health team. So today we're here to request respectfully for the Board of Health to endorse and submit a letter to the concerned ministry regarding a provincial alcohol strategy. As we know, alcohol use remains a leading preventable cause of morbidity and mortality in Ontario. Alcohol causes injury, addiction, disease, and social disruption. Yet alcohol is the most widely consumed psychoactive drug in Canada. As shown in the stats in the report, it's based on the Canadian Community Health Survey from Statistics Canada. Nearly 4 in 5 adults in Ontario have used alcohol in the past year, and 42.6% of Ontario residents report exceeding either Guideline 1 or Guideline 2 of Canada's low-risk alcohol drinking guidelines, which are sent as attachment number 2. So the risk with this is that alcohol is causally related to chronic disease and injury, and according to the World Health Organization, it's been identified alcohol as second only to tobacco as the leading risk factor for mortality and morbidity. As far as the increasing availability of beer coming into grocery stores, research has long established that increasing access to alcohol will lead to increase in alcohol use and misuse. We have studies from BC and Alberta that shows that privatization actually increased rates of alcohol-related death in BC as well as suicide mortality rates in Alberta. So that's why we are concerned with the actions by the Ontario government to increase access to alcohol. There was discussion when the government announced in 2015 budget. The Ministry of Finance committed to working with the Ministry of Health and Long-Term Care to develop initiatives to support the safe consumption of alcohol. Since that announcement in December of 2015, work on the policy has been stagnant, and the government has yet to produce or communicate any comprehensive approach to address the harms of increasing access. Also, alcohol has significant costs to the individual and society from both a health and financial perspective. Alcohol harms extend beyond the user and impact family, friends, working relationships, and communities. Addressing the harms of alcohol use has major implications for local police, EMS, fire services, the healthcare system, as well as public health. It is estimated that Ontario incurs a net loss of $456 million from alcohol-related healthcare and enforcement costs relative to alcohol revenue. So it's important to note that in most provinces, the revenue from alcohol does not exceed societal costs from drinking. That's why we're calling on the government to both fulfill its promise and prioritize the health and well-being of Ontarians by enacting a comprehensive evidence-based alcohol strategy as soon as possible. Other provinces that have already implemented a provincial alcohol strategy include British Columbia, Alberta, Manitoba, and Nova Scotia. In addition, several boards of health, namely Wellington, Dufferin, Guelph Health Unit, Grey Bruce Health Unit, Middlesex London Health Unit, as well as Timiskaming Health Unit, have recently passed resolutions supporting the call for a comprehensive province-wide strategy. As Marlene stated, this is the call is for a comprehensive strategy that includes socially responsible pricing of alcohol, limiting retail outlets and hours of sale, as well as alcohol marketing controls, since evidence shows these are the three most important effective interventions, especially when paired with education and awareness, as well as targeted interventions such as drinking and driving countermeasures, enforcement of the minimum legal drinking age, and screening and brief intervention referrals. We respectfully request the Board of Health of Haldimand Norfolk Health Unit to join the call to action by the Ontario Public Health Association and other public health units by endorsing and sending a letter to the Ministry of Health and Long-Term Care regarding a provincial alcohol strategy for Ontario. Thank you.
Done. Mr. Wells, we'll start with you. Questions?
Thank you very much, Mr. Mayor. I do have a question, and thank you very much for your report. It was very well presented. And as I read this and listened to the report, here's what I got from this. That we know the access to alcohol, the more access we have, the more health care costs we get. That's the equation. Make it easier to get, more people get it, more health care costs. So it's a pretty simple question, Mr. Mayor. Why do we do that? If we already know what the results are going to be, why do we put ourselves in that situation? And that would be my question, Mr. Mayor. Does she have any idea why we go down that path?
Through the chair, we have been advocating a long time through different health agencies and collaboratives advocating against privatization because, as you said, we have the research that backs it up. Unfortunately, sometimes the call gets louder for having more access, and people look at U.S. having access in even local convenience stores. So sometimes our government is not listening to the health aspect, but instead is looking at ensuring that they're hearing the other side where people are saying they don't have access, as well as they're saying that they're using it to boost the economy. So unfortunately, this is the situation where we're at, and that's the only thing I could say to that. Thank you.
If I understand it, though, the reality is the more government gets in revenue, the more they have to spend in health care. Am I correct on that?
Through the chair, the way it's set up is the Ministry of Finances, where the revenue is coming in from the LCBO. So contrary to the popular belief, people think that LCBO is the cash cow for the government, which it does generate income. However, the Ministry of Health spends in healthcare as well as enforcement costs. So the two different ministries are working in two different ways. So that's one of the downsides to the way things are governed in Ontario.
My last comment, Mr. Mayor, is just a general one. The more you're in government, the more you realize we're not too smart. Thank you, Mr. Mayor.
Bit of a vicious circle. Mr. Oliver, thank you. Mr. Wells.
Thank you, Mr. Chairman, and those are certainly good comments. My question, though, to you, you did mention at the beginning of your presentation to us that I think BC and Alberta already have such comprehensive strategy that we would be asking our province to implement?
Correct. So there is learnings that we can glean from some of the provinces that
That's where I
have
was
that.
going to go with
Thank
my
you.
question is, have you personally had a chance to look at the documents that comprise those strategies? And assuming you have, and I hope you have, do you feel they contain things that would make things better in Ontario? In light of Member Wells's comment, I mean, it's as obvious as the nose on our face, and yet we're still not doing things. How much different would having a strategy formalized make things in Ontario? Are there innovative ideas in those other strategies that you feel could and should apply here in Ontario?
Through the chair, what I can say about, we know what works. Some of the key levers, as mentioned, are the top population interventions, which are, taxation, as well as a limit of restriction of advertising of alcohol, as well as the second one is, sorry, I just have to look at my notes. The second one is also limiting of retail outlets and hours of sale. And then the second one are targeted to people that already are experiencing some form of alcohol harms. So we have targeted interventions such as drinking and driving countermeasures, enforcement of minimum legal drinking age, and screening and brief intervention and referral activities. So those are what experts have studied, and that's what we're suggesting should be enacted into a comprehensive alcohol strategy for Ontario.
Thank you for that response, and I support that. The one thing, and I want to make kind of a general comment as well as my colleague did, one of the fears I have about this is that we ultimately, in the local health unit, could end up having to enforce some of these new rules just like we do with the tobacco enforcement program. And I think a number of us around the Board of Health table or the Council Chamber table sometimes feel that we're spending money on things in terms of the tobacco enforcement that, number one, are not effective, and number two, are obviously expensive. So that's just my general observation. I'd hate to see us become the alcohol police just the same as we are the tobacco police locally. That's an observation, but I do support what is being suggested today.
Thank you. Kim, a comment, please?
Yes, through you, Mr. Chair. To the councillor, we do have at Public Health a comprehensive alcohol working group that does meet and regularly is consulting with our stakeholders in the community. So if Board of Health is interested, we would be happy to bring back a report to you that outlines what that comprehensive strategy is and some of the activities that Haldeman Norfolk Health Unit does to help ensure that there's safe consumption of alcohol within our community. Pardon me? This is what we're doing already, and then also what we have kind of on our work plan, our operational plan for 2018.
Mr. Columbus.
Thank you, Mr. Chairman. Thank you for your deputation or report. It mentions in the report from OPHA that there are 206 grocery stores will be allowed to sell alcohol by July 1st, 2017, which is passed. So your one initiative here, item 2, limit of retail outlets and hours of sale. Do you have any ambition to try to turn that around? Like the province has already indicated that they're giving licenses to these people, these markets. You're just trying to prevent further ones from happening, is that it?
Through the chair, yes, we have been advocating against privatization and further weakening of alcohol controls, but now that it's happened, we're trying to ensure the province has a comprehensive alcohol strategy that looks at all these different things so that the alcohol-related harms are mitigated. And as far as the number of alcohol sales in grocery stores, by September 29th, which we already had 300, it's risen up to 300. So that's one of the issues is we're saying the government is going to further weaken the alcohol controls while not working on the alcohol strategy.
So you're telling us that they've actually exceeded their expectations of 206?
So through the chair, July 1st, alcohol was available in 206 grocery stores. I have an updated from OPHA, the Ontario Provincial Alcohol Association, Health Association. I have, the number has gone up to 300 as of September 29th because it's a bidding process. And at the end of 2018, they're saying they would go up to 450 stores.
Okay, as a follow-up to Councillor Oliver's question, this, with respect to time spent, do we have any indication of how many dollars and hours are spent by health unit staff on the alcohol file issue? Like how many persons are involved with the whole program? I think we know what tobacco involves, but how many on the alcohol file?
Through the chair, I am one FTE on alcohol, but I sit on creating the comprehensive alcohol strategy, but I have other portfolios as well.
Great. I guess we don't have an exact figure then.
Sorry, through you, Mr. Mayor, to the councillor. We do have one dedicated FTE, I would say, or suggest through our budget process. But that is something, if you're interested, I can get the particular numbers back to you and report back on that when we bring a report back around what this comprehensive alcohol strategy looks like for Haldeman Norfolk Health Unit.
Okay. Thank you for that.
Thank you. Mr. Block?
Thank you, Mr. Chairman, and yeah, I don't know who to ask the question to, but anyway, I attended an alcohol symposium or mini conference, I don't know what you called it, in Jarvis a while back, and I thought there was going to be some follow-up to it, and I got an email that said it's just, I guess, wait or whatever, but I don't know what's happening with that. Is that all part of this, or where is that alcohol symposium? I know I spent the day there. It was very, very interesting. I thought there was going to be something coming out of it. I don't know who could answer that.
I'll answer that. Through you, Mr. Mayor, to the member. We are finalizing that report. We had some staff changes over the summer. We wanted to make sure that the report that we present back to our community stakeholders was robust, and that the stats were reflected accurately, and that the report was presented in a manner that was useful to many of our stakeholders in the community. So that report of finalizing touches are being made, and we expect it to be out by the year end.
And how does that fit into what we're doing here tonight?
So through the mayor to the chair, this request for this report is one piece of that larger comprehensive alcohol strategy under advocacy. So the request for us to send the letter for the provincial alcohol strategy is part of the advocacy arm of what we do at the Haldeman Norfolk Health Unit under advocacy.
Okay, so it does form part of it.
It's part of it, yes, that's correct, sir.
Okay, thank you. Thank you.
Mr. Sonnenberg.
Thank you, Mr. Chairman. I don't have a question. I want to thank the presenter for the report. It was very interesting. You know, people have been brewing alcohol for thousands of years, and we all know the health implications. The Americans tried to put a stop to it back in the Prohibition days. I think that lasted for 14 years to no avail. It had no effect. People just, yeah, it made people want it more. The simple truth is people like the escape from life that a little high from alcohol provides. So unfortunately, it's carried to extremes, and there's all kinds of societal implications there. So what we have coming up now is increased outlets for alcohol. We have legalization of marijuana on the horizon. We have wineries and breweries popping up all over. We think it's great for the economy. Okay. And then we have the opioids. Man, things don't look good to me, Mr. Mayor. Thank you.
I thank you for that question. Thank you. Councillor Brunton?
Thank you, Mayor Luke.
Question to the presenter, please, and then we can
thank you. Good report. And I read this at the advisory committee, and I got to ask this question on page 90. Page 96 of the report. It gives these limits. It says, reduce your long-term health risks by drinking no more than, and it gives some statistics there. I found them, well, first of all, my question is, where did they come from? Are they a local statistic that you've derived, or are they a provincial how did you get a?
Through the chair, are you referring to Canada's low-risk alcohol drinking guidelines? Yes. So those are national